On behalf of Echosens North America, I'd like to thank you for joining this webinar entitled Evolving Diagnostic Strategies for NAFLD and NASH. I am Jerry Mayberry, the moderator of today's event. Today's event is funded by Echosens North America, the suppliers of the FibroScan technology. This presentation includes information on the uses of FibroScan from published literature. Echosens does not intend to make any specific claims found in this presentation. The FibroScan is FDA cleared as a tool to aid in the clinical management of liver disease and is not intended for the treatment of any specific liver disease or condition. I would like to begin by introducing our featured speaker, Dr. Stephen Harrison from San Antonio, Texas. Dr. Harrison earned his medical degree from the University of Mississippi School of Medicine and completed his internal medicine residency and gastroenterology fellowship at Brooke Army Medical Center in San Antonio. Additionally, he completed an advanced liver disease fellowship at St. Louis University. He is board certified in both internal medicine and gastroenterology. Dr. Harrison served as a professor of medicine at the Uniformed Services University of Health Sciences and is currently a visiting professor of hepatology at Radcliffe Department of Medicine at the University of Oxford. He is a past associate editor for hepatology and is currently an associate editor for alimentary pharmacology and therapeutics. He is a peer reviewer in over 20 medical journals and is internationally known for his work in hepatitis C and non-alcoholic fatty liver disease. Dr. Harrison recently retired as a colonel in the United States Army. During his time in the Army, he served as the Director of Graduate Medical Education at Brooke Army Medical Center. And with that, I would like to introduce our featured speaker, Dr. Harrison.
Thank you, Tony. I appreciate that. And thanks to everybody joining in today to kind of get an overview of fatty liver disease and evolving diagnostic strategies. I think there's a lot of development that's occurring now. There's a lot of information that came out at NAFLD. And I think we're in an exciting time. We're in a period where hepatitis C is starting to take a back seat to fatty liver. And there's a lot of things we need to still learn related to diagnosing the disease, who we should be screening, and then treatment. So we'll try to get through a little bit of that today in the next hour. So if you just sit back and relax, maybe have lunch, and let's go through this together. All right, guys, here we go. So evolving diagnostic strategies for NAFLD and NASH. These are my disclosures. I think it's just important to list that I work with a lot of different pharmaceutical companies and device manufacturers in trying to find treatments and diagnostic strategies for patients with fatty liver. So I thought we would start here where we're talking about just whetting your appetite for fatty liver disease. And this is really interesting. So this is new data that comes out of the American College of Gastroenterology meeting this past fall, where they looked at people under the age of 50 that were transplanted for fatty liver disease, and it turns out that now fatty liver is the #1 indication for liver transplantation in this age group of less than 50. So we had talked for years that fatty liver disease was gradually increasing in its indication for liver transplant and that it would soon pass hepatitis C. And now we see for the first time, at least in patients under the age of 50, that that's actually occurring. So we'll focus now on epidemiology and natural history. And I want to talk first about this seminal paper put out by Zoberi Onasi's group in hepatology this past year, where it looked at kind of a systematic literature review focused on epidemiology globally for fatty liver. And you see the spectrum, the spread from 13.5% to 30.4%, and the overall prevalence of about 25%. Now, this is using multiple different ways to determine the prevalence, from abnormal liver enzymes to right upper quadrant ultrasound to MRI technology. And so this isn't really a true head-to-head comparison of prevalences using the same modality to determine the prevalence. So I think I want to look a little bit closer in the U.S. literature. So let's go to the next slide here, and we'll talk about at least 2 studies that have been done recently, and then I'll talk about a third one that's ongoing. And so I'll draw your attention first to the Dallas Heart Study. In this study that was published now close to a decade ago, 30% was the overall prevalence of fatty liver disease, and this was done using MRI technology. We see the prevalence is higher in Hispanics than Caucasians and African Americans. When we look at the San Antonio study, this was a little bit different study. This was done in patients over the age of 50 presenting for routine colon cancer screening. And at the time of their colon cancer class, where they learned about colonoscopy and how to take the prep, we asked them if they would like to know their liver health. We excluded patients in that trial who had a known history of fatty liver, had known history of other liver disease, or drinking alcohol to the amount that we consider it outside the realm of fatty liver and more alcohol related. So that's less than 3 drinks a day for a man and 2 drinks a day for a woman. And we found that with ultrasound technology, the prevalence was 46%, so a bit higher. Now, these 2 studies were done about 6 years apart, so there's a couple thoughts here. One, 2 different technologies, MRI for the Dallas study, ultrasound for the San Antonio study, and so maybe there's a little disparity, a little difference between the 2 modalities. MRI is clearly more sensitive than ultrasound. And the other thought is, well, there's been a lapse of time and maybe the prevalence has increased. You see the same Hispanic, Caucasian, African American distribution of fatty liver. Now, the next point is NASH. Where we're really limited now is how there are very few studies looking at the overall prevalence of steatohepatitis. And this is done by liver biopsy. So in our cohort of patients who had fat on ultrasound underwent a liver biopsy, and the overall prevalence was found to be 12%. And if you had an imaging study that showed fatty liver, 1 in 3 of them had fat or had NASH. So let's move forward to a current study. This is the prevalence, again, of fatty liver and NASH in South Texas. This is done here in San Antonio. About 670 patients have been enrolled to date. It's the exact same study that you saw before with ultrasound, where the prevalence was 46%. In the same cohort of patients presenting for routine colon cancer screening, except now we're doing multiple imaging modalities. They get a FibroScan, they get a CAP score, they get an MRE, they get an MRI with proton density fat fraction, and they get also this novel technology called liver multiscan, which is a multi-parametric MR, and we'll talk about that when we get to imaging. But here you see the prevalence is 40.7%. So if you just took this number and compared it to the Dallas Heart Study a decade ago, we've gone from 30% to 41%. And this is in roughly the same patient population using the same technology. So I do think there's been an increased prevalence of the disease over the past decade. When we focus on diabetics, we're up to 75% having fatty liver, and then 61 for Hispanics, 60.5 for non-Hispanic whites, 27% for African Americans, and on down the line. And then when we look at the right side of the graph and we focus on NASH, again, we're biopsying people that have fat on imaging, and we see the prevalence is about 8%. So it's less than the 12% before, and I think this maybe has a little bit to do with the pathologist that is reading the slides. It's a different pathologist now than there was when we did the first study. But I think the important thing to note is it's 8%. That's still significantly higher than what's in the published literature. And if you go back to the diabetics, the prevalence of NASH in that cohort is about 26%, or about 3% higher than the general population. Okay, so what about the natural history of the disease? Now, I think this is important because if we say there's 100 million Americans with fatty liver, I think it's important to tease out that about 70 to 80% of them have isolated fatty liver or fat with mild inflammation that really they have a very low risk of progressing to fibrosis and a low risk of death over time. Alternatively, if you have NASH, that is the group that is at greater risk of disease progression to cirrhosis, decompensation, and liver cancer. And what we know now amongst that cohort is that if you have fibrosis, that portends a worse prognosis. So think about this as we get to imaging modalities. If we could eliminate the 80% of patients who don't have disease that's progressing, that's an important step. that's saying, okay, let's focus our energy on the 20% that have risk of disease progression. So I think one of the things we're going to look at moving forward is what modality will help us exclude those patients that really aren't at risk of disease progression. And then we'll also focus on NASH with varying degrees of fibrosis. So this slide really says the same thing, but with a caveat. And this is some recent data published by Dr. McPherson's group in UK and Newcastle in the UK. And it talks about, unlike hepatitis C and hepatitis B, where we think disease steadily progresses over time, this disease kind of waxes and wanes a bit. So about 20% of people will actually have improvement in fibrosis without doing anything. About 40% will remain stable, and about 30 to 40% will progress over time. And this was a study done in 108 patients with a median of 6.6 years of follow-up. I think that's important to talk about. This disease kind of waxes and wanes, and I think that correlates well with the liver enzymes, because you see in people with fatty liver, enzymes will wax and wane a bit. And this is what I think lulls some of our primary care providers, even gastroenterologists, to sleep a bit with this disease, and that they see them intermittently, and liver enzymes are up one time, and then there's a recommendation made to lose weight and exercise and maybe decrease the statin or whatever, and then you see them back and the liver enzymes are improved, so we think, well, the patient must be getting better. And I'll talk a little bit more about liver enzymes in a few minutes, but it's really not a good marker of disease severity. So let's move on. So we'll now focus on risk factors for NASH. And here I want to break them down into clinical and histologic. We'll first talk about histologic, since we were just on liver biopsies. And I think the important thing to take home here is that fibrosis is really what predicts the risk of people progressing with their liver disease. And then inflammation, but mainly portal inflammation. So this is more, the disease typically is more lobular based, but as you progress in severity of disease, you see more and more portal inflammation. And then you see the diagnosis, the Gestalt diagnosis of NASH, and then finally ballooning. And there's the hierarchy here. So advanced fibrosis is more predictive than overall fibrosis, which is more predictive than inflammation, and so on. Now let's talk about clinical factors. So older age, and I think, you know, I have the caveat here, I'm 47, and the older I get, the older that older age becomes. But I think it clearly is over the age of 50. Male gender, it's a male predominant disease until females become postmenopausal. And then postmenopausal females rapidly catch up and pass the men with both prevalence and severity of disease. And then probably one take-home point I would love for you to walk away from this lecture knowing is that metabolic syndrome is really a predictor of patients that are likely to have NASH and progress to cirrhosis. And so if you had to hone in on a group of people that you wanted to biopsy, it would be a fatty liver patient with full-blown metabolic syndrome. And then diabetes is critical. You've seen the prevalence amongst diabetes and the fact that 26% in my cohort of diabetics with fatty liver have NASH. So that's a single predictor it's independent. And even a family history of diabetes is important. Now these next two, AST and ALT ratio and low platelet count, suggest that patients have advanced liver disease. And I look at the ratio of 1. So when the AST and the ALT are the same number, that's a bad sign. I saw a patient this morning that had an ALT of 41 and an AST of 41, and the first thing I do at that point is look at the platelet count, and it was around 160, 170. And that suggests to me that this patient is starting to get a bigger spleen, starting to sequester platelets, all as a result of some scarring in liver, portal hypertension. So if you have a ratio of 1, look at the platelet count. If it's less than or close to 150, that's a sign the patient probably has a lot of fibrosis in their liver, if not cirrhotic. And then finally, PNPLA3 genotyping is certainly predictive of NASH and NASH with fibrosis, but we don't check for that, and it's not routinely available in clinical practice. So let's go back to the liver enzymes. And I have just really 3 bullet points here that summarize the data. An ALT can be normal in up to 60% of NAFLD patients with NASH. Conversely, ALT can be increased in up to 53% of NAFLD patients with no NASH. So subsequently, ALT really is not a good predictor of NASH, and it can't tell you that the patient doesn't just have fatty liver disease. So I don't really use the ALT that much. Now what I do like is the AST. As the AST rises over time, you see a progression in fibrosis. And really, as the AST crosses 40, that's where we begin to pick up NASH, and that's where we begin to pick up NASH with fibrosis. So I'm going to take you through a couple slides where we talk about clinical predictors of advanced fibrosis in NAFLD, and then we'll talk a little bit about mortality. But here you see hypertension, diabetes, combining those two, and then hypertension, diabetes, and obesity all gradually increase the odds ratio for advanced fibrosis in NAFLD. And this kind of really gets back to my point I made about metabolic syndrome. When you have full-blown metabolic syndrome, where they're hypertensive, diabetic, and obese, it really puts that patient at significant risk for NASH. So here, I want to focus on disease progression and mortality. And really, we'll start with the upper right-hand picture, which is mortality and transplant risk. And let's look at those hazard ratios. Here, you don't really see a big jump until you get to stage 4, and you see a hazard ratio of 3.35. But if you look below, and you look at liver-related events risk by fibrosis stage, at a fibrosis stage of 2, you begin to see a hazard ratio of 2.26. That's where we really think patients are at increased risk of developing a liver-related complication at stage 2 or higher. So keep that in the back of your mind as we start to look and think about your patients in your own practice and who might be at risk. And this, quite frankly, is another reason why we do liver biopsies. I hear people all the time tell me, well, if we don't have any treatment for this disease, why are we subjecting patients to liver biopsy, and why does it matter if we diagnose NASH? Well, here's the reason why. At a diagnosis of NASH with stage 2 fibrosis, their prognosis is different. And patients want to know what their prognosis is when you tell them that they have a disease. Okay, what about treatment? And I think this summarizes it pretty well. Let's first focus on lifestyle modification. And here you see an elegant pyramid that talks about weight loss, and weight loss correlating to different aspects of liver biopsy characteristics. And so if you're just losing 3% of your body weight, you're going to begin to see fat loss. I think that's important to tell your patients. But you're not really improving the hepatitis. And here you've got to really get up to 5–7% weight loss before you begin to see resolution of disease. If you really want to make progress, you've got to get to 9–10% weight loss before we see fibrosis regression. And remember, if fibrosis is the holy grail for disease progression, obviously that's what we want to see start to go away. And so you really have to begin to get close to that 10% weight loss before we see a benefit. Now, you'll see this statement come out in the new practice guidelines for fatty liver. I am part of the committee that's writing those guidelines. And what we came up with was a combination of a hypocaloric diet, daily reduction by 500 to 1,000 kilocalories, and moderate to intensity exercise. So here, more than 6 METs. You need to be sweating and unable to speak in full sentences when you exercise. And that's what we call moderate intensity, not where you're panting for breath, and that's intense. That's really dramatic intensity exercise. We're talking about moderate. That provides the best likelihood of sustaining weight loss over time. Now, what about current pharmacotherapy? And we really want to just focus on vitamin E and pioglitazone here, and let's look at the evidence. Well, the evidence is there's good evidence for the use of vitamin E in NASH without diabetes. If we look at limited or insufficient evidence for its use, it's in NASH with diabetes or cirrhosis. And then if you look at the AASLD recommendations, it's really NASH without diabetes for vitamin E. And the dose would be 800 international units a day, and you have to make sure that they're using the RRR alpha tocopherol, which is the naturally occurring vitamin E. With pioglitazone, NASH with or without diabetes, there's good evidence. There's limited evidence for NASH with cirrhosis, and the guidelines say it can be used to treat steatohepatitis or non-alcoholic steatohepatitis. There's a dose-response relationship, so 30 is good, 45 milligrams a day is better. And with metformin and pentoxifylline, it's either no evidence that it works in metformin's case or very limited data with pentoxifylline. So let's shift gears now and talk briefly about novel therapies. So these next 3 slides are going to look at steatosis, then NASH, and then fibrosis. And you see here the results from separate studies. Now, none of these are head-to-head trials. The time points and populations may differ between the studies, but I put this up here to show you this is the published literature for each of these different modalities. And I highlight the fact that almost all of them have statistically significant improvements in steatosis, except for elafibranor and cenicriviroc. Now, what about for NASH? Same group of studies, again, not head-to-head. The maroon bar graph is the drug, and the green is placebo. And you see here for resolution of NASH, you get pioglitazone, liraglutide, elafibranor, all reach a p-value that's less than 0.05. And bariatric surgery, in the right patient population, does a really good job at resolving steatohepatitis. Okay, let's go to fibrosis. Now here it's a little bit different. If we set fibrosis as kind of the holy grail of trying to prevent progression of liver disease, then we really want our drug to have an effect on fibrosis. And here, so far, the data suggest only 2, obeticholic acid and cenicriviroc, are meeting that endpoint. Of course, bariatric surgery is as well. I think there's no data yet on elafibranor, and we still need a bit of work with pioglitazone and vitamin E. But I think where we're really targeting our future therapies is on resolving fibrosis. Now, can we do it by resolving NASH? I think we can, but it's going to be resolve NASH, and then your own body comes in and cleans up the fibrosis through its naturally occurring wound healing response. But 2 of these drugs actually target fibrosis directly. Now, what about the competitive landscape? And I do kind of a stop sign here. So green is phase 3. They're closest to getting FDA approved. Yellow is phase 2B, and red is phase 2A. And what you can see is a lot of drugs are in development. But looks like GenFit's elafibranor and Intercept's obeticholic acid are the furthest along. They're actively enrolling in phase 3 currently. And we're hopeful that these trials will fill sometime in 2017. And then we just have to wait the requisite amount of time to get the data output to see if they can get Subpart H approval and subsequently get FDA approval for the drug. These other drugs are moving along. Cenicriviroc is moving hopefully into phase 3 in 2017. And simtuzumab, interestingly, which is a monoclonal antibody against LOXL2, was a company, the company Gilead had a press release recently suggesting that this drug is not going to move forward in development. So this one will probably come off the list, and the others here are still in study. So what about new diagnostic approaches to NAFLD? And the question that comes up often is, can we identify NASH non-invasively? And the answer still today is no, we can't, but we're getting closer. And ideally what we'd like to do is to not only diagnose NASH, but diagnose NASH with different stages of fibrosis. And here I've highlighted for you stage 1, stage 2, stage 3, and stage 4. And just to kind of give you the bottom line answer up front, we're pretty good at predicting stage 3 and 4. What we have a little bit of a problem in now is separating stage 1 from stage 2, and then stage 2 from stage 3 and 4. But we're moving along in that regard. So with that in mind, I want to move forward into telling you a little bit about the data. So when we look at non-invasive tests, we can look at kind of what I call wet biomarkers, or the clinical or laboratory tests, and then the imaging modalities. And we'll talk only about NAFLD fibrosis score and the FIB-4 index as part of this talk, but I want to let you know there are others that are out there as well. So what about the NAFLD fibrosis score? Well, this has been extensively studied. It was originally derived and validated at the Mayo Clinic by Paul Angulo's group, and it was a large number of patients that had fatty liver, and they did multivariate analysis and found that each of the factors listed were predictive of advanced fibrosis. Now, they weren't predictive of NASH, they were predictive of NASH with advanced disease. And they took two different cut points, a low and a high cut point. And on this graph, you see, or the table, you see the negative and positive predictive values. Now, subsequent to that, because this has kind of been validated in multiple other studies, it's kind of become an acceptable way to evaluate patients with fatty liver. And there's even an online calculator available called NAFLDscore.com, where you just put in the variables listed, and then it spits out the score, and you have an idea if the patient's at low risk, intermediate risk, or high risk for advanced fibrosis. And the FIB-4 index, while originally designed for co-infection, has now been studied in fatty liver, and it's pretty predictive as well. And you see the two different cut points here. And on the next slide, we see that there's also an online calculator where you just put in the age, the AST, the platelet count, and the ALT, and it spits out a number, and you can then stratify patients into low risk or high risk. We'll come back to this at the end when I kind of roll up an algorithm for you and how to evaluate patients. So if we look at a study that compared multiple non-invasive tests, you see that the center purple graph looks at the negative predictive value. And they're all really good at excluding advanced disease. But when we look at the positive predictive values, only the NAFLD fibrosis score and FIB-4 give us anything of 75% or better. The others not so much at positive predictive value. So even with the NAFLD fibrosis score and the FIB-4, we have room to go as far as their positive predictive values. But it can be helpful, I think, in the right setting. So now let's shift gears and talk about the imaging modalities. And the first one we want to talk about is transient elastography. And this is commonly known as FibroScan. It's based on a technology called vibration-controlled transient elastography, or VCTE. And it allows painless and simultaneous measurements of two different parameters: liver stiffness, which correlates to fibrosis, and CAP, or controlled attenuation parameter, and that correlates with steatosis. And both are really assessed on the same volume of liver tissue, which has been analyzed and shown to be about 100 times bigger than what you get with a liver biopsy. So there are three different dedicated probes. I highlight the bottom two because this is really more focused on adults, but there's an M probe for the general population and an XL probe for the obese population. And while liver stiffness measurements are available on all probes, only the CAP is available on the M and the XL probe and not the S probe. Now the good news here is you get both the CAP and the liver stiffness measurement with one probe. So you don't have to have a different probe for CAP and a different one for liver stiffness. You get the same, you get two different answers with one probe. So let's talk a little bit about some of the factors that affect stiffness, because remember, stiffness isn't always just related to fibrosis. So if you swell the liver with hepatic congestion from heart failure, that'll give you a false elevation. Eating a meal within a couple hours, 3 hours of getting your fibroscan done will also cause congestion. And then if you have active inflammation, amyloid, sarcoid, cholestatic liver disease, that also will give you a falsely elevated number. So keep those in the back of your mind as you're reading these out. So here's just a picture of what you'll get when you do a FibroScan, and a little bit of a focus on CAP here. So controlled attenuation parameter, this is the blue number, 174 you see in this picture. And I'll talk about cutoffs and what we think the number is where fat begins to occur in the liver. And the max CAP score is 400, meaning that if you have a CAP of 400, that you really have a significant amount of fat in your liver. And we'll come back to the lower number when I show you a little bit of data, but I think around 240 to 260 is where less than that you really don't have fat in your liver. And I'll show you some data to support that. And then the other number is here, the 4.8, that's the kilopascal, and that's the number that correlates to fibrosis. And I'll also show you some data that suggests if you're less than 5, you probably don't have anything to worry about from a fibrosis perspective. So let's look at a little bit of that data. So this is a study published by Lee this past year in PLOS One, and it looks at discrimination of NASH using transient elastography in patients with fatty liver. And there were 183 patients enrolled. Their mean age was just over 40, and about half had NASH and about half had non-NASH, NAFLD. And here on the left you see CAP on the vertical axis in graph A, and on the horizontal axis steatosis grade. And if you see S0 there, that correlates to about 220 or so. Less than that, patients really didn't have steatosis. But you see, that's the mean number. The higher end here can get close to 240, even 250 when you look at the whiskers. And then you see a stepwise increase as you go to S1 and S2, and it kind of plateaus a bit when we're out there at between S2 and S3 at between 300 and 350. Now in graph B, here you see liver stiffness measurements measured against the different stages of fibrosis, and you see a nice correlation between the different stages of disease, but really gets good separation here between F2 and F3 and F4. So looking at this paper a little bit closer, if we look at the diagnostic performance of liver stiffness for assessing fibrosis in NAFLD patients, if we look at F0 versus stage 1 to 4, you see the optimal liver stiffness cutoff is 6.7 kilopascals. Remember, this is in a Korean patient population. And if you look at F0 to 1, so very, very mild fibrosis versus moderate to severe disease, we increase that cut point to 8. And then if we look at F0 to 2 versus F3 to 4, so now focusing on advanced disease, we're up to a kilopascal cutoff of 9. And then if we're wanting to find the cirrhotics in this Korean patient population, you saw the number at 11 kilopascal. So now let's look at fat, and this is looking at CAP in the same study. 247 was the optimal cutoff to exclude fatty liver disease, 280 for mild, 300 for more advanced. So again, you're looking for a number that says patients don't have fat. In this Korean population, less than about 247 would get you that. So let's look at the U.S. So in the U.S., we have one study published in the American Journal of Gastroenterology this year by a group out of Harvard. Tapper was the lead author. And this looked at 164 patients just using the M probe. And everybody got a liver stiffness measurement, and they broke them down into 3 different patient populations. They called you low risk if you were less than 7.9 kilopascals, so a little bit different cutoff than the Korean cohort we just looked at. But here, if you were less than 7.9, and there were 67 of those patients, none of them have advanced fibrosis. So, caveat, it doesn't mean they don't have NASH, it just means they don't have NASH with advanced or stage 3-4 disease. Alternatively, if your kilopascal score was greater than 9.8 and 43 patients had this, and again, just by the M probe, half of the patients had advanced fibrosis. Now, if we look at the intermediate range, they're between 7.9 and 9.8. They repeated it. This was only in 10 patients. But if they repeated it and it was less than 9.8, only 1 patient had advanced fibrosis. If it were less than 9.9, I'm sorry, this should have been greater than 9.8. There was a typo in the paper. Less than 9.9, then there were no advanced fibrosis patients. So suggesting that, get the score again if it's intermediate between these 2 numbers, 7.9 and 9.8. And if it comes out to be low again, meaning less than 10, none of those patients had advanced disease. So the take-home point from this study is really greater than 10 is where you begin to think about, and this is with the M probe only, the patients probably have some significant fibrosis going on. So let's look at another paper, and this is screening diabetic patients, and I get this question a lot. Should we be screening diabetic patients for fatty liver? My own bias is yes, we should be, because patients get diabetic hepatopathy. You saw that from the original prevalence study I showed you, where 75% of diabetics have fatty liver, and up to 26% of them will have NASH with fibrosis. So it makes sense to me that we should be screening an at-risk population. Now, the pushback I get is, well, there's no treatment for it yet. Well, there may be no treatment for it, but we do have a lot of clinical trials. We do have diet and exercise, and we do have pioglitazone and vitamin E. But also remember prognosis. You're prognosticating these patients for their long-term risk. In this study, an interesting set of data came out. This study looked at CAP scores less than 222. So remember, less than 247 in a group of Korean patients. This study is more patients from China or Hong Kong. Here they chose 222 as a cut point to say no fat versus fat. And then they took it a little step further and they stratified according to ALT, and they looked at normal ALT and what their liver stiffness measurements were. And really only about 6% of people with no fat and normal ALT had elevated liver stiffness measurements, as defined by greater than 9.6 kilopascal by the M probe or 9.3 by the XL probe. And then if you looked at CAP scores greater than 222, so those people that were thought to have fat, it turns out that about 13% of people had abnormal kilopascal scores. Now, if we look at the high ALT group, we picked up a little bit more, 9.2%, that had elevated liver stiffness measurements and low CAP scores. But we really saw a rise when you had a high CAP score suggesting fat and you had an elevated ALT. About a quarter of those people actually had an abnormal kilopascal score. And then ultimately we can move on to the diabetic patients and focus on them. Around 18% had increased liver stiffness, and a lot of those people wound up having NASH on biopsy. So this next graph kind of summarizes the US data, the European data, and the France and Hong Kong data, or European data, and you see it's pretty close. pretty worrisome if your FibroScan numbers are greater than about 8.5 in the US, greater than 10, and not so much if it's less than 7 to 7.9. So I'm going to quickly move through because I want to leave some time for question and answers. I just want to show you a couple other modalities that we're working on. This is one called ARFI and also the Air Explorer. There are other ultrasound waves that look at shear wave to assess stiffness. And this is a comparison of supersonic versus FibroScan versus ARFI. And in the upper left-hand corner, you see the reliability of the tests are all about the same. And if you look in the bottom left-hand, the ROC curve for significant fibrosis, again, a lot of them are they're all three about roughly the same. And then for advanced disease as well. And how about MRE? Now, I think this is really powerful. MRE, to me, is really, really good at telling us about the severity of fibrosis in patients. And I show you this one study by Rohit, a good friend of mine, published a couple years ago, looking at stage 3 to 4 fibrosis. And the cutoff here, I show you this because it's different than the FibroScan cutoffs. They're a little bit lower on their KPA. Here, greater than 3.6 KPA predicted stage 3-4 disease. So don't confuse FibroScan kilopascal with MRE. They're a little bit different, and they use the same technology, but we get a little bit different score. And we know that MRE is really good at predicting fibrosis. You see the AROC curves of 0.92, and you see the breakdown of the different stages of disease, all greater than 0.86. So I really like this modality for determining fibrosis. The problem is it's not point-of-care testing, and so we can't use it in clinics, and it's sometimes a bit of a challenge to get the MRIs. This next graph really compares MRE to FibroScan, and really, when we're looking at stage 2 or stage 3 or stage 4 disease, not a lot of difference overall in the kilopascal scores or the AROC curves, and I think that's important. However, in the bottom, you do see that if you look overall, you do get a better AROC, at least for milder disease with MRE. Once you get out to stage 0, 2 versus 3, 4, very similar ROC curves. So I want to highlight liver multiscan real quick. This is an MRI-based multi-parametric tool. It looks at a corrected T1 image of the liver. There's no IV, no contrast needed. It takes about 12 to 15 minutes to get this scan. But it really gives me a clue about inflammation and fat in the liver. Not so much fibrosis. I think MRE and FibroScan maybe are better for that. But this tells me a little bit about NASH versus no NASH, inflammation, that sort of thing. And it's, I'll skip this slide because I want to jump to this one. It's color-coded. So green is good, meaning your lift score is about 1.5 or less. Orange is kind of a little bit like a stop sign. Pump the brakes. There's a problem here. And red is bad. So here you see lift scores of less than 1.5 green. Lift scores in the 2 range are orange, and greater than 3 are suggestive of significant NASH or significant inflammation with fibrosis. And you find that it's predictive of long-term outcomes. And I highlight this paper in J. Hepatal published this year that suggests lift scores of 3 or greater actually predicted within 27 months a likelihood that patients would have a negative outcome. So I think this may hold promise moving forward. I give you 2 examples. This first one is a patient with fat in the liver, 11.1%, but no real significant NASH or fibrosis. And this next patient has really limited or no fat, but probably cirrhosis or at least NASH with some significant fibrosis. So I want to kind of end here by going back a bit to our prevalence study that we have ongoing. And this is data that was presented at the liver meeting this year a couple weeks ago. And I just want to take you through 670 patients enrolled, 388 have completed FibroScan, multiparametric MRI, and MRE, and about 172 went to biopsy, and you see the breakdown of normal patients, fatty liver, and NASH. And we'll just kind of briefly go through that. And I want to just tell you also, I think this is fascinating data. Of the 30 NASH patients, 12 of them had stage 2 to stage 3 fibrosis. And remember, these are asymptomatic patients that are walking around that have no idea they have liver disease, but 12 of those 30 are at risk of developing a liver-related complication on a slide I showed you previously. So for fat, let's look at that. These are ROT curves, and once you get above really about 5% fat, you begin to have fat in your liver, and you can see 8.3, 17.3, and 27 really nicely and very elegantly break down different stages of disease. And I think really proton density fat fraction is now the gold standard for quantifying fat in the liver. But it turns out CAP is actually not bad. If we look at CAP, and again in our study, about 268 is what predicted no fatty liver. 270 was really grade 0 or minimal fat, and then grade 1, 320, grade 2, 360, and it tended to flatten out a bit between grade 2 and grade 3. But the ROT curve here is still very good, 0.87, 0.86, 0.85 at predicting the degree of fat in the liver. Now, I wanted to just do a couple correlations. This is comparing MRI to CAP, and you see it correlates very nicely with advanced steatosis in the red circles. And if we look at the green diamonds, again, that's stage 2 steatosis or grade 2 steatosis. And there's a nice correlation between liver multiscan, proton density fat fraction by MRI, and CAP. Now let's look at these next 3 graphs very quickly are going to tell us a little bit about NASH and how good these are at predicting NASH. And I think this is really a good take-home point for you. At a LIF score of 2, if you cut the LIF score arbitrarily at 2, you would pick up almost all the NASH patients by these black dots. You would miss 3. But you would prevent doing liver biopsies in 48 patients that did not have NASH. Now, if we looked at FibroScan, the mean FibroScan for NAFLD was 6.18, and for NASH was 9.7. But if you drew that cut point at 5, really you would only miss a few NASH patients, but you would prevent doing liver biopsies in 51 patients that had fat, but no NASH. So keep that number in the back of your mind. And then for MRE, 2.2 versus 2.9, but if you drew the line at 2.2, you would exclude a lot of NAFLD patients that didn't have NASH, and you would only miss, again, a couple that had NASH. And then if you correlated MRE and FibroScan for fibrosis stage, you see an R here of 0.7, a really nice correlation between MRE and FibroScan. So we'll summarize by talking a little bit about management strategies. I think it's important to identify those patients at risk for NASH and disease progression, and that's really by looking at these clinical risk factors. I told you early on, if you have metabolic syndrome, that alone kind of puts you at an increased risk for this disease. But I would also argue diabetes also does as an independent predictor. And then what about non-invasive markers? Well, we're fairly accurate at diagnosing advanced fibrosis, but I think lesser cutoffs on imaging in combination with other factors can predict NASH, and I'll show you that on the next slide, with pretty good accuracy. I think also we can reliably exclude advanced fibrosis, but not NASH. So I'll end with this summary slide that was published by Arun Sanyal and Mary Ranella. I think it's pretty good. If you have a patient with hepatic steatosis, and whether or not the liver enzymes are elevated or not, I don't think it matters. And if they have fatty liver, you can do 3 things here. If they're low risk profile, if their BMI is less than 30, their age is less than 40, they have no diabetes or metabolic syndrome features, and you do those 2 non-invasive scores, the NAFLD fibrosis score, the FIB4, and you really get low numbers, or the FibroScan is less than 5, I think you can follow the patients clinically. You can tell them to lose weight and exercise, but I don't think we need to go to liver biopsy. Alternatively, if they have an AST that's greater than the ALT, remember this is an ALT predominant disease, so now when we're shifting and we're getting an AST that's equal to or higher, a platelet count is low, or the FIB4 or NAFLD fibrosis score are high, or that FibroScan is greater than 11, then I think we either need to call the patient advanced disease or we need to get a liver biopsy or MRE to confirm. And really the conundrum is this middle group where their BMI is in the obese range, they're over 40, they have multiple features of metabolic syndrome or diabetes, and they have this intermediate score for FIB4 NAFLD fibrosis score, and their FibroScan is between 6 and 11. That's the group I really think we need liver biopsies in to confirm. So kind of to summarize one more point, remember, if you can exclude 80% of people with fatty liver that aren't at risk of disease progression, that's this group in green, all right? That's what you really want to focus on. This intermediate group is where I do think we need to do liver biopsies to confirm. And with that, I think we're wrapping it up here. I'd be happy to take any questions. Thank you for your attention.
Thank you, Dr. Harrison. This is Jerry Mayberry with Echosens North America. I've been monitoring the questions in the background. Several of you have asked if you will be able to access a recording of this webinar event. I will say that all of you will be receiving a follow-up email message with a link to view the recording of the event, share it with colleagues as you wish. Now I would like to pose some questions for Dr. Harrison. First question, does weight loss help those with cirrhosis?
I think it does. You know, I think it depends a little bit on the severity of the fibrosis. The analogy, you know, when we quantify fibrosis, typically we're using the NASH CRN scoring system or the Brunt classification, which only has one category for fibrosis, and that's stage 4. But if you look at ISHAC, which is the way we stage Hep C and Hep B, for instance, there are really 3 different stages of cirrhosis. So I think our hands are a little bit tied with fatty liver in that we just say you're cirrhotic or you're not. And really it comes down to compensated versus decompensated. I think in well-compensated cirrhotic patients where their albumin is relatively preserved, their INR is relatively preserved, but there's really biopsy-proven evidence of cirrhosis, or clinically there's evidence of cirrhosis, I think we can make that patient better with weight loss, again targeting 10%, and we get that data from the bariatric surgery literature. I think if you become decompensated, however, you have ascites, encephalopathy, variceal-bleeding, probably not going to make a lot of progress with weight loss alone. They probably need some additional therapy.
Very good. Next question. When you prescribe vitamin E, what dosage do you prescribe?
So the data suggests that 800 international units to 1,000 international units are what gives you the best probability of finding success. But remember, that needs to be the naturally occurring vitamin E. That's the RRR alpha tocopherol.
Next question. When using VCTE and CAP to monitor patients with NAFLD for progression, what is considered significant change?
Well, I think that's a good question, Jerry. We're still trying to sort out what a significant change over time would be. And I think you have to consider the coefficient of variation when you look at any imaging modality, whether it's MRI or an ultrasound-based elastography. What we know from the literature is that there is a little bit of variation with FibroScan over time. I think my own gestalt is you need to have more than a 30% change before we call that significant, worsening over time compared to their baseline scan. And that's for liver stiffness. We don't really know yet for CAP what that coefficient is going to be. And I don't think we've really ironed it out for liver stiffness. That's just more of my gestalt based on what my experience has been.
Next question. In type 2 diabetes, do you recommend prescribing pegloticone via the endocrinologist?
No, I think that with pioglitazone, there's enough data out there. We published the first randomized trial in New England Journal back in 2006 with pioglitazone. Ken Kuzi, who is an endocrinologist, is a big advocate of pioglitazone, and I've used it for years in treating patients with fatty liver disease. I think you can use it. You don't need to be an endocrinologist to use it. The beauty of pioglitazone as a PPAR gamma agonist is that it doesn't induce hypoglycemia like a sulfonylurea will. So we're not at risk of putting patients at harm from hypoglycemia. The problem with pioglitazone, you have to remember, is there's a black box warning for heart failure, and patients are at risk of weight gain as well as small bone fracture risk and bladder cancer risk. So I don't think it's a medicine I'd like to use long term, but it's a potential bridge to future therapies or a clinical trial.
In the same lines, what are your thoughts on milk thistle?
I have very little thoughts on milk thistle. Milk thistle doesn't work in liver disease. It doesn't work in Hep C. It doesn't work in NASH. Both studies have been done already. So I would not recommend it unless patients have extra money to burn.
Very good. And I have a final question before we're out of time. This question relates to the fact that we know that steatosis is almost absent in NASH cirrhotics. What is the biologic principle for reduction of steatosis once we reach the level of cirrhosis?
Yeah, this is something that's been bugging us for several years now. We're not clear exactly why steatosis regresses as fibrosis progresses. There is one study that's been published in Hepatology that suggests that as you go from lower stages of fibrosis to more advanced stages of fibrosis, that adiponectin levels actually increase in these patients' livers. And we know that in the setting of fatty liver disease, patients have low adiponectin, and in patients that are normal, they have higher adiponectin levels. So paradoxically, there is some evidence to suggest that adiponectin levels rise actually as you progress in disease severity, and that may be one mechanism, although again I don't think it's confirmed, by which patients resolve their steatosis. But yeah, it's a conundrum that we don't fully understand.
And one last question, if we may, Tony, before you conclude. Dr. Harrison, what do you think the role of coffee is in liver disease? We're seeing it in the literature quite a bit.
Sure. I think if you look at one drug that has the best data for fibrosis and liver cancer, it's coffee. We don't know what drug, what chemical it is in coffee that has a protective effect, and we don't have prospective randomized controlled trials to show a benefit of coffee, but every every cross-sectional study that has been looked at and published has shown a benefit of coffee and fibrosis. And the odds ratios are somewhere around 0.6, so a 40% improvement over time in fibrosis, and even prevention of liver cancer. The one caveat with coffee is that decaf doesn't work, and caffeine-containing compounds like chocolate and tea and sodas, like diet sodas, don't work either. So really, I tell patients it needs to be drip coffee. It doesn't matter if it's Folgers or if it's Komodo Dragon at Starbucks. It just needs to be regular coffee.
This concludes today's webinar on the evolving diagnostic trends of NAFLD and NASH. On behalf of Echosens North America, I would like to thank Dr. Harrison for his informative presentation. Participants can access a recording of this webinar by visiting the Echosens North America website at www.echosens.us. Again, www.echosens.us. Thank you.